Hi, Michael Jaff, live in SCAI 2015 in San Diego. I'm here with James Wilentz from New York, and we're here to talk about a very important topic for the SCAI entire audience and all of you, and that's superficial femoral artery interventions. Thanks for joining me.
Absolutely.
So you spend a lot of your time doing this. Tell me just in general, are you excited about the prospects of interventions for SFA disease going forward?
Well, I'm excited about it, but as you know, it's been a bugaboo. I mean, we've had really, great hopes for plain stents as opposed to balloon angioplasty, which has been borne out to some degree. We've had the Supera stent, which is conformable and has changed some of our practices, but we're still confronted by the problem, especially in the SFA, which, as you know, is a conduit vessel, of the frequency of restenoses and, in fact, of total occlusions in our previous intervened areas. So it remains a major problem for us.
So we're going to talk about three major categories of advances in therapy for SFA disease. Let's start off with atherectomy. Tell me about what you think of the literature and where it fits into the standard practice now for SFA disease.
So, as you know, the entire field of peripheral intervention has been somewhat like the Wild West, and the literature has been full of really non-randomized trials, but we've had some good trials about jetstream atherectomy, including jetstream atherectomy and ISR. We've got directional atherectomy trials, all of which suggest at least a signal for lower restenosis rates and also lower dissection rates on original treatments. There are some important technical facts. People have looked at really what is an optimal atherectomy. If you are achieving not as good as a 30% residual stenosis at the end of your atherectomy, you're very much less likely to have a long-lasting result in some of the trials. So these are some of the important points.
So we're going to come back to atherectomy towards the end. Second topic is drug-eluting stents. As you know, the coronary world's had those for a long time now. I think the data supporting that is quite clear. What's your perception of what we know about Zilver PTX as the only FDA-approved drug-eluting stent for peripheral artery disease?
Well, certainly all the studies of Zilver PTX have shown advantage, and this is something that we have been using for quite a while. The problem with Zilver PTX is that in highly calcified lesions, we're still left, if we're using that as a standalone, with a stent that's never going to be as well expanded as we'd like. And we're seeing higher restenosis rates in the real world than what we're hearing in the literature. So I think we start to get into a world of very individualized therapies. Now, we talk about our need to respect evidence-based medicine, and that's clearly very important. But when you get down to each patient, the same kind of thinking that goes into how you design a trial and what you include and what you exclude is not the same kind of thinking that you have for an individual patient. So in a highly calcified patient with a short lesion, you may want to do an excisional or a directional atherectomy of that calcific area and put in a Zilver stent. In a very long lesion, you may have a totally different approach.
And then the third big category would be drug-coated balloons, obviously available outside the United States, largely in Europe for a long time, but now we have two FDA-approved drug-coated balloons. So how do those fit into the treatment algorithm?
So, we have really good data from the IMPACT SFA trial and the IMPACT Global trial suggesting very low TLR rates early on, certainly a slightly disturbing signal of continuing loss of that low TLR rate out at about 24 months in the Italian trial. But we are using that. I have one patient in whom we have Zilver stents in one limb and drug-coated balloon in the other. And maybe next time at SCAI we can come back to say what this non-randomized controlled study shows. But even using the drug-coated balloons, we have to be, again, alert about some of the technical aspects. So, we're used to looking for beautiful results of a stented vessel. And as an operator, you've got to get ready to see it's sort of back to the future. You got to remember that the way angioplasty works is essentially a controlled dissection. We've known that since the time of Andreas Grunzig. And with a drug-coated balloon, you're going to see dissections, and you have to stay your hand unless there is a truly flow-limiting dissection or a severe remaining stenosis. And I think that we're just learning about this. The other thing I think is really important is the concept of combining modalities. Again, I don't want to dwell too much on this, but in very bulky lesions and in in-stent restenosis, I think many of us are moving towards the combination of atherectomy with drug-coated balloons, and there is some literature to support that as well, as you know.
So going forward, there are a couple of exciting things. The 2-year data from Levant 2 and Impact SFA will be released relatively soon. I think that'll be important going
Absolutely.
to your point about what the longer-term durability is. I do think this combo therapy of atherectomy and drug-coated balloons is an exciting one. The definitive AR study, really not powered to show a difference, did show that in certain lesion types it helped.
Certainly in the long lesions and the highly calcified lesions, the definitive AR study shows a clear signal and that this was better to use atherectomy plus drug-coated balloon.
So that's going to need a larger follow-up. And then just last week, the first ever results from the Boston Scientific Majestic study on their drug-eluting stent showed a whopping 94.4% primary patency at 9 months with lesions that were more complex than enrolled in the initial Zilver PTX study. So I think the field is exciting, lots going on. Thanks for your leadership in this.
Absolutely.
And thank you all, SCAI 2015 in San Diego.
Great.